Hi, everyone. Welcome to Pediatric Grand Rounds. I'm going to start with our land acknowledgement. We would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. And I'm going to now ask our director of our residency program, Meg McNamara, to introduce our speaker for today.
Thank you very much, Rafi, and good afternoon, everybody. I am delighted this afternoon to introduce Dr. Anthony Luke, who is a professor of clinical orthopedics here at Benioff Children's Hospital, and he's a distinguished professor in sports medicine and the director of the UCSF Human Performance Center. Dr. Luke was the first primary care sports medicine physician at UCSF in 2003. He completed his family medicine residency at University of Toronto, then did a fellowship in pediatric sports medicine at the Boston Children's Hospital, followed by a Master of Public Health at Harvard. He has long been interested in sports injury prevention and digital health. He has directed the UCSF Play Safe program for the past 20 years, which includes bringing athletic training services to the public and private schools in San Francisco and providing free cardiac pre-participation physical examinations to the Bay Area student athletes. And today we have the privilege of hearing him speak about hot topics in sports medicine, Back to the Future. And I also just want to express my gratitude because as a primary care and general pediatrician in the ambulatory space over the last several decades, the work that you've done to expand access to trainers at the school and do the cardiac pre-participation exams is really much appreciated. So without further ado, Dr. Luke, thank you.
Great, thanks. I always love giving grand rounds for pediatrics and working with the department. And as you heard, when I was invited to give the talk, I was just thinking about what topics to do. And this is kind of my 20th year here at UCSF. And I just thought back at all the different topics in sports medicine. And I was just thinking, wow, some things really haven't changed and some things are changing a lot. So I titled this Back to the Future, and I'll explain why in a bit. My disclosures are around digital health work, but I don't think either of these will affect the talk today. So as we all know, history is essential for taking care of our patients. And when you think about it, you read a textbook, it's like, hey, how do we take care of patellofemoral pain, or how do we do a concussion treatment? We see what we see now, but it's kind of interesting looking back over the years. How did we get to where we are right now? So I also realized that I'm kind of getting into my mid-career or older mid-career, and some people haven't actually seen Back to the Future now. So that's a little scary, but if you haven't, this is a great movie. Without ruining it, you have Marty McFly, who's a teenager, and basically he's got a dad who he doesn't think is the coolest, or parents that he doesn't think is the coolest, but he has a friend named Doc Brown who invents a time machine. And you can understand how these time machine movies work. But basically, he goes back in the past, meets his parents when they were young, sees what they were like. Obviously beats the bad guy Biff, and it's a happy ending as history gets changed. But the big thing is like figuring out where you were before and how things got to where they are, and what changes might need to happen is really the premise here. So some of these are actually older slides that I gave like almost 15 to 20 years ago. So the statistics of just sports injuries in children, they estimate that a third of all the injuries are related to sports. And interestingly enough, there isn't great epi studies that give us much better numbers right now. So it's still super common. One of the number one things you're going to see in outpatient or in the ED related to injuries. but kids are still participating a lot in organized sports. At the time, like 20 years ago, what were the risk factors at the time? Like we know for pediatrics, growth is the unique risk factor for those athletes. And then training is the biggest extrinsic risk factor that we got to be careful about. So things haven't really changed that much now. You look at all the other general things, but really, I think for a pediatric athlete, still the growth and the unique features with that and how much can they take is still the big risk factors. And so why do kids get injured in general? A lot of times in youth sports, you'll see that we're training them sometimes like we do for adults. So let's say you play baseball and you have some 8-year-old throwing from the pitcher's mound, which is like maybe not the right distance for them at that age. But maybe you have some college or ex-college coach or a parent who used to play, and they're just doing what they're used to doing. They'll just train the kids the way they normally do. Kids do get tired faster. They're just, not as strong and as fit. And so even some of the expectations from training, they're not getting as strong as if an adult were to lift weights. They're not going to get those strength gains or even the fitness gains that you would from training. There's definitely flexibility issues. We're going to touch on that. Kids being more flexible when they're young and then going through the growth spurt. And so all of this kind of leads to overuse, right? You've probably heard all those papers that you see all the time, overuse injuries in young athletes. And so a lot of these factors are why. But let's dial it up to 2023 and what has happened in youth sports. It's a huge market now, bigger than the NFL. So for those of you who are getting excited about Saturday's game, there's more dollars in the youth sports market. Now a lot of athletes are into the single sport specialization. And I know some of my colleagues have come over to talk about that. And really, a lot of parents just want to do the best for their kids, right? The kid's interested in one thing, but you got to imagine these youth sports clubs are about kind of getting them skilled, but that's their business to keep them into that sport. So a lot of times they don't even want their kids, their athletes playing in their school sport, because if they get injured there, they can't play on the club. So if you guys have your patients or young children at home who have gone through this, you can see the push and pull that it's not really about participating and hanging with your friends. It's about you got to do this because you won't get to this team if you don't do this one. If you don't play in the summer, you don't get to the fall team, and so on and so on. And now you've got actually dollars involved with this, with all the NCAA rules. Now you might have even heard of like popular kids who are getting recruited for college, getting some sponsorship deals for their likeness. So that's getting all the way down to the high school level. And then on the flip side, you've got physical education classes just being kind of slowly whittled down at schools, mainly because of time in the curriculum, facilities, all of these kind of things are always tough. So, I think there's been changes in just how the culture of youth sports is. So let's talk about 3 kind of general stories that I'm going to go over. We're going to talk a little bit about how we just treat some general musculoskeletal injuries, in particular ACL injuries. We're going to talk a little bit about concussion and then talk about pre-partition physical exams. So what were we talking about 15 years ago? I don't think the problems that we run into are much different now than they were back then. For traumatic things, we're really worried about those growth plate fractures, mainly because they're unique to the pediatric athlete. And if we miss them, you can get growth disturbances. We got to be very careful, as opposed to treating them for adults. For the atraumatic things, the same problems, apophysitis is that overuse at the growth plate. Osteochondritis dissecans is kind of a funny kind of problem that we still don't have the full etiology on. There probably is some kind of overuse, overtraining phenomenon that affects that underlying bone. But as you may know, sometimes you can get intact cartilage, but loss of blood supply to the underlying bone that gives you a potential problem, which could actually cause a loose body, like say if it happens in the knee, or it'll just cause chronic pain in an elbow or something in a baseball player or something like that. And then you're probably familiar with Perthes and leg cap Perthes and the avascular necroses. Those are usually covered very well by our pediatric orthopedic surgeons. So again, that unique growth plate, if you think about it, just remember what can go wrong with those things. And these are the physeal injuries. Hasn't really changed. Like there is some argument, is there really such thing as a grade 1 Salter fracture? Like some people will argue there's always a little bit of the metaphysis. Be it as it may, I think what we just want to look out for is that we don't get those more advanced ones where you almost get the crush injury to the growth plate. And those are ones that definitely the pediatric orthopedic surgeons want to see early and just manage them properly. So when I was finishing fellowship and I was at Boston Children's Hospital, we were always still talking a lot about how do you preserve the ACL, because the ACL tears are happening more and more in young athletes as they super specialize in their sport. And then how do you do the surgeries on the young athletes without violating the growth plate? So they did all these fancy different surgeries where you're doing extra articular kind of reconstruction so you don't have to drill through the growth plates. And we'll kind of show you what's going on now, but these are different techniques that we're talking about. And what about just anterior knee pain? I don't think this differential diagnosis has changed a lot either. So if you're working in outpatient, you're going to see these all the time, you know, with patellofemoral pain and Osgood-Schlatters disease being probably the number 1 and 2 problems if they're going through the growth going through puberty. But don't forget about patellar instability. Again, we're going to talk about hypermobility in young athletes, but that kind of contributes or is a risk factor for that patellofemoral pain. And in terms of management of anterior knee pain, you probably heard about this. Like this is kind of like the textbook. Every review article talks about, you know, quad strengthening exercises and maybe some braces and straps for whatever the particular problem is, and then surgery being a pretty rare kind of occurrence that's recommended. How has things changed? What's different in my clinic? I think maybe more education and talking about those risk factors. We're still going to do the symptomatic treatment, like the normal, you know, protected or modified activities, ice, compression, elevation, all the usual things that you guys probably do in outpatient. But we think a little bit more about biomechanics. We like to evaluate them and how they move. And I'm going to talk a little bit about how the lower extremity moves and how you might manage your anterior knee pain. So just as a quick evaluation, just for some pearls for the residents and such, when I'm looking at lower extremity alignment, I just want feet together. That's when I'm looking at the hips, the knees, and the ankles. I want to see if they're knock-kneed or they're bow-legged. And then I want to get them feet shoulder width apart, go on their tippy toes. And that's where I'm looking at their arch. I want to see, are they maintaining good arch? And as they come down, do they collapse a little bit? Because you've probably heard of the miserable malalignment syndrome where they got a little femoral anteversion, knock-kneed, pronation at the feet. That's not a good setup, as I'll show you in a few videos about, you know, lower extremity alignment. You want to make sure they're not antalgic. If they can't hop, that's a bit of a red flag for me. And so that's just a quick screen for any lower extremity evaluation. For the kneecap specifically, I want to feel underneath the kneecap. So sorry that one video is not going, but I'll basically stick my finger underneath the patella. So you can use 2 hands to examine, move it over and get your finger right underneath that. But we talked a little bit about patellar hypermobility. Oops. Okay. So you can take both hands and just shift it side to side. If it moves around the quarter of the width of the patella, that's kind of normal. If it's going more than a quarter, they might be a little more hypermobile. And they usually are more hypermobile laterally, but you can have some kids going both ways. Now, as a caveat, like if you got kids under 10, they're definitely pre-puberty. They can be pretty flexible, as you've seen in the young kids. They're just like Gumby. So that everything feels a little loose. But if they're getting a little older, and they're still mobile and they got kneecap pain, again, that's where hypermobility you got to think about, because usually those kids get a lot of pain over the medial facet because the kneecap's sliding in and out of the groove, so it's rubbing on that inside. So that's where they usually are sore, on that medial patella. And just to give you some statistics, hypermobile kids, they get a lot more sports injuries, dislocations. Here's saying they get 3 times more shoulder injuries, including dislocation. And then also in another kind of registry, they noticed that kids that had more mental disorders, they also had the co-diagnosis of Ehlers-Danlos syndrome. So you can imagine some of these kind of entities can correspond together, whether pain and chronic issues cause more mental problems or there's something else with these patients. But that definitely, hypermobility is something that I always check for, even in my adult population. But definitely if that kid that's, you know, not improving the way you expect them to, definitely check for hypermobility as a risk factor. Now during puberty, this is usually for the guys, the young athletes, you know, they're 13, 14, they're going through their growth spurt. They might get the other way. They might get too tight, very tight on the hamstrings, as you kind of see on the picture on the right, or their quadriceps, and they get more patellofemoral pain. They usually have pain laterally. So one thing, if you don't do this in your office, just a dynamic single leg squat. It's super helpful on the functional side. Like any kid should be able to do that. He's very good. Like his pelvis is very stable, so it's not teeter-tottering. But if you even try it yourself, you'll see some people, they can't really control their torso. They start wobbling. They can't really do it with good alignment, or they often go into a knock-knee alignment. That's kind of a setup for a lot of anterior knee pain and other injuries, as I'll show you. So that's not a good position we like to see. So you see that, that's a good patient to send to physical therapy to get that cleaned up. And the reason why that is often it's the hip. So what we've learned over the past decade is how important the core is and the hip muscles are. If you watch pro sports, you'll see all the athletes are now doing core workouts and Pilates and all this kind of stuff. Like I think in the 80s, there's none of this kind of stuff. But that's because you get the Trendelenburg. If you remember that from medical school, when you're standing on the one leg, if those hip abductors are not working, that's why they start getting that collapse and going into that knock-knee approach. And that miserable malalignment makes it even harder. Like you can see those kids that have that femoral anteversion, that knock-knee approach, is just harder to maintain that alignment. So that's why it's so important that if you get that, or you notice that education where work on your core, work on your hip, very important. So as you can kind of see here, here's a young runner here. As you slow it down, you see her knees, they are in that little bit of a knock-knee appearance. And then when you look at her pelvis, we put those little dots on. As she's running, she's teeter-tottering. That's where those hip muscles aren't really working as strong as necessary, and she's getting that little Trendelenburg effect. So she's going a little bit knock-kneed every time. You can't really see the bike behind it. And that's something that's a really simple tool that the physical therapist can use. If you've got your cross-country runner or track seasons coming up soon, if you get that person that keeps getting patellofemoral pain and they can't do that single leg squat, that's where PT comes. And this is Dr. Souza. He's my colleague in the Human Performance Center. He leads our research, but his whole PhD was around this whole concept that femoral anteversion really affects your biomechanics, leads to patellofemoral pain, especially in young female athletes. And it's because those hip muscles aren't strong. And that's been pretty much widely adopted. So if you ask your your athlete who's not getting better, hey, and they're complaining PT is not helping, show me your exercise. And they're only doing the quad stuff. They're missing all that core stuff. So little things, little pearls, definitely check for spinal alignment. You don't want to miss a scoliosis that's affecting their alignment as well. Check that Trendelenburg with that single leg squat. Make sure there's no leg length discrepancy. But physical therapy is pretty much the way to go. If you find that there is hypermobility, you can do some taping, bracing, things like that. Those are very helpful. But for the most part, patellofemoral pain, still education, good therapy, and then modification of stuff. So these are the examples of that hip stuff. So if you guys do Pilates and stuff like that, you probably do this all the time. But these are the simple things. Like if they can't get to PT, maybe they can watch a YouTube video of this stuff. It's all over the place. So unless they're not motivated to do it, it's simple to educate them and get them to do it. So you've probably done maybe these side-to-side walking. If you guys have had knee problems, been to PT, that picture where the guy is pushing his knee open, like in ballet dancing, where you're turning out, you're working those rotators and hip abductors. And if you can do some side planks, those are always great. Now, load management is something you hear about. If you're an NBA fan, you hear about it all the time. People resting the star players, mainly to get them to not overload. Interestingly, the NBA just released some of their research that showed that load management didn't actually prevent injuries. But for some of us older athletes, I'm sure a couple of days of rest doesn't hurt for sure. So stats are always tricky, but I think it's the concept that you're looking at both subjective and objective measurements, but not just physical, also the mental stuff for your young athletes that are doing a lot. And with now, like, you've got things you can measure outside. These are simple things. How much do you lift? How many pitches do you throw? That's an example of something that we've done really well in load management. If you have young baseball players, we have all rules about how many pitches they can throw, and that's actually reduced a lot of elbow and shoulder injuries. But internally, I think is where the future is going to go. We're going to kind of get more subjective of how hard this is for the athletes. And I think with wearables, if you guys have your own Fitbits and Apple Watch and all this kind of stuff, at the pro level, they're all using these data monitoring things. Like they'll monitor their sleep, their heart rate, their mood, all of it. And it won't be too long for your iPhone's going to tell you you're stressed out and all that kind of stuff. All right. So going back to the ACL injury, remember that valgus alignment? That's where you get that exact same motion, that valgus collapse. And that's how the ACL, like her foot's planted, externally rotated. That's the mechanism where it goes. And that's so we just don't like valgus. Sorry, I'll just keep playing this. Sorry, I see people wincing. Sorry about that. So interestingly, like ACL reconstructing, we often used to wait until you get to skeletal maturity and then reconstruct it like an adult surgery. But sometimes what do you do for a 9-year-old or 10-year-old that unfortunately injures themselves? Out of Children's Hospital Boston, Dr. Martha Murray came up with this construct. She actually puts a little sleeve in there, and that little red thing is it's injected with some autologous blood, and they basically put the ends of the ACL and sew them together inside of a sleeve, and then put some more growth factors and stuff like that to augment the healing. So stuff that you guys have probably heard about is orthobiologics, how we're using a lot of growth factors to maybe repair things. But that's been an interesting way for the pediatric orthopedic surgeons to take care of some of these ACLs, and they're starting to experiment with them in adults as well. So we might start getting into repairing ligaments instead of always reconstructing them. And so far, at least for these younger patients, they've been holding up at 2 years. So different technology that's coming around. Now, who should you refer to? You guys have great in-house people at at the Children's Hospital here. This is Dr. Pandya, who's our chief of pediatric orthopedics now, but he's a sports doc. He's mainly out of the East Bay, but he does come over here as well. So just if you have not met him, he's kind of a social media guru now. He's like on the radio. He's on the what's that sports show, KBNR, or he's on there as Doc Pandya. So great guy and great surgeon. And most of the surgeries now are all arthroscopic, not as many open procedures. So I do think that if athletes have a bad problem, they probably should see a pediatric sports specialist, or at least someone who's familiar with dealing with young athletes. Because with all those growth plate stuff, if they don't do it a lot, like an ACL reconstruction, and there's growth plates, you don't want someone who's doing it once a year or twice a year. And just to kind of give you one tip that's worked for me, and it stands true for the last 20 years. This is what Dr. Lyle McKaylee taught me. He was kind of considered the grandfather of pediatric sports medicine. He started it over in Boston Children's. He always told me, how do you decide when someone gets to play? And it really doesn't matter whether it's an ACL, it's patellofemoral. It's really, you got to ask yourself 3 questions. Can the athlete return safely? If you don't think there's a medical problem that they're going to really hurt themselves or worsen a problem, that would check off on the medical side. So that's kind of our job. Can they be effective with their sport? So can they actually do it? And that's where you stem that functional stuff, or talking to the coach and stuff like that will really decide, can this person actually participate in their sport? And then I always like to ask the athlete, are they relatively pain-free? Because if they're not having fun, you probably run into those scenarios that maybe the kid doesn't like that sport and the injury is like the reason, or they really do have pain and the parents are really wanting them to go because they paid like X amount of dollars for that team already. So just kind of think about those things, because if it's no to any of these, then you can kind of be pretty kind of safe saying don't play right now. All right, we're going to shift gears now to concussions. And so this is a long definition. That's what we were talking about like 15 years ago. So we knew there's something that was going on in the brain and there was trauma involved. But there was also tied to imaging, because imaging wasn't widely used. We'd mainly do CT scans and stuff like that. But normal imaging was kind of the definition. But you've obviously done a big workup, and that's been a long time if they're doing all these things before they make the diagnosis. And loss of consciousness was still discussed, if any of you remember that. At the time, there was all this controversy about what the grading system would be. Everyone was trying to make a way to define and categorize everything. And the traditional one was the Cantu, again, and a neurosurgeon in Boston. He kind of was pretty popular from the American Academy of Neurology. And so, people were still sending all the concussions to neurology, right? So it was all based around whether they got knocked out or had amnesia. And it was based on an arbitrary 15 minutes. And if those are the things, you just graded them, and if it was a grade 3, basically they're definitely out. Grade 1s, you could kind of like just rest them a little bit, but the anticipation was this person's going back very quickly. And so it was mainly based on some simple studies that just showed that most people got better after 7 to 10 days. So that they kind of moved it to a different system where if it was simple, you're resting around 7 days, and that's what you tell your patients. And then if they're more complex, they had all this loss of consciousness and stuff, then you'd be telling them it's, I guess, more than 7 days. So it was very rudimentary. And we don't have a lot of the buy-in from coaches and schools and stuff like that. So every time someone had to go back and have accommodations, you'd basically be calling the vice principal to fight with them about telling it really that the kid has a concussion. Now, at the time in 2005, we were just getting into neuropsych testing. And the whole return to play thing was very vague. But, dial it into 2023. They just had the 6th meeting. They've been having these large conferences where the same experts pretty much have been meeting for the last 20 years to just define what people should do. And I think the new thing that they've had is they've upgraded all the tools. So I don't know if in outpatient clinic you have some of these tools printed out and utilize them, but if they're still on the SCAT-5, now there's the SCAT-6, and there's also some new tools that I'll kind of discuss. In terms of the definition, it's pretty much the same thing, but just a little simpler, just still a direct blow, but not only to the head, can be anywhere on the body that might shake the brain enough and cause a functional disturbance, but no imaging questions. We don't really grade them as bad or good or anything like that. It's just a concussion. But unfortunately, we still have lack of studies in the youngest age group, like 5 to 12. It's just hard to do those studies. Now, I'll bring your attention to one kind of tool, because most of you, if you are an outpatient, unless you work in the ED, you're probably going to see them a few days after the concussion happens. They've got an office assessment tool. And I think the big things are they have a report for the child and the parent, but updated questions on a few of the subdomains. They've got a little bit different age-specific tools, like some of those memory tools were universal. Now they have some that are more kid-friendly. They're validated as well. And so the big idea is to still be somewhat individualized with your concussion care. Like, you're just supposed to use these tools as a guide to direct you on the topics maybe you got to think about. And then also they recommend using a multidisciplinary team, because like I'm a primary care sports doc. I do have to rely on my physical therapist and eye specialist and neurologist if I run into more problems. And so it's good to have a team of what's going to happen if this person's not getting better. Mental health and sleep are added screens. So these are your standard depression, anxiety tools, but they do have an extensive validated sleep tool as well. So these are all free online. So if you want to print them for the clinic, so they're available, but it does take a while. So I don't know how much time you get for your patients on a concussion, but in sports clinic, when it's 15 to 30 minutes, this fills up a lot of time. So we're lucky we have athletic trainers to help us, but if you have someone that can ask some of these screening things before you get in there, because they'll take a while. How many of you guys are familiar with the vestibular ocular motor screening? Do you guys do that now? And it's important, like, because balance and eye stuff are probably the newest changes in the evaluations. Headaches, that's easy to ask for, they'll tell you. But those subtle cases, a lot of them have these eye and balance problems. So easy ways are the kid that's having trouble watching television, gets really motion sick when they get in the car, or just difficulty reading. They sometimes can't do the tracking because the brain and the eye coordination isn't going. And so these are just examples. As you see, there's a courtesy of Nick Hadamia. He's one of my colleagues. He did a really amazing concussion grand rounds for our own orthopedic department. So that one's on YouTube. So if you want to go really granular and see some of these things in action, I'll refer you there. But just for sake of time, I won't do most of them. But a lot of them are just like your normal nystagmus. And then the other one is the saccades, where you keep your head straight and you just look left and right. So you can even try it on yourself, like how annoying that is after a while. And if you had a concussion, that doesn't feel so good. So you do it side to side as well as up and down. And then you kind of do that more the tracking ones, where you kind of can bring your thumb, you can kind of move your whole body and get them to stare at the thumb and move their torso. Oops, sorry about that. And then also keep their head still and just use their eyes. And then you do that sideways and then up and down. And oftentimes it's more the sideways ones that really bother people. Up and down, not as much. But you'll often find they have difficulty with those, and then they'll be complaining of their balance and their motion sickness and things like that. And then finally, the near point convergence, you just basically bring the pencil until they kind of see double, and it'll happen earlier than expected. And so what you're looking for, if they complain of headache, dizziness, nausea, or fogginess, any of their usual symptoms, and then that's where you might refer them to physical therapy for vestibular ocular PT, where they often do a lot of these balance things. But there's also eye specialists. At Berkeley, there's a really good group, and they specifically do all the eye stuff, because that's a little bit unique. They do say that, you know, in your normal assessment, you're looking at all these other things. We touched on balance. Some groups are actually measuring blood pressure and heart rate for the vasomotor changes that can happen. Some people will even exercise them, because there's some studies that show exercise tolerance is related to concussion recovery, and then a lot of in-depth psychological and neuropsych tests. Some of those computerized things, if you've heard of those, like Impact, that's probably falling a little less in favor, because they haven't really been shown too much to help clinically in getting them back. It's more just to get a quantified number to protect people a little bit more, not as practical. In terms of treatments, there's a lot of things in that paper that kind of go over the evidence of what works. Even simple things for their headache. It's not just the NSAIDs, making sure, you know, they sleep on time and eat well and all those kind of things is really important. Getting good PT if they do have neck pain related to the headache. But a lot of kind of wellness things that are part of maybe not something you would have thought of for concussion. And then balance, neuromuscular training, the sleep stuff, people are using melatonin. And then, of course, the anxiety and the concentration things. There's a lot more counseling and treatments for those. This paper is kind of really helpful for me. Does anyone use this one? It's by the California Interscholastic Federation. It's all the suggestions on accommodations that your athlete can have, because definitely the first things to get them relatively asymptomatic, but getting them back into the routine and back to school will probably help those families quite a bit. And those are those big areas, and they have the recommended levels that they can do for each of these areas, like whether you want to give them a break or it's mandatory or just on demand. For visual auditory, do you need to sit the person forward or get them bigger sized print and things like that, or audiobooks? Those are all in there. So it's nice and easy to just check box it and you don't miss anything. And they're all very cut and dry. So when you bring it to the school, they know what you're saying. And these are that graduated return to learn. There's really good information about kind of what the levels are. Certainly you want them just to be comfortable at home, but then next step is getting back to school. And then it's, and then homework is always kind of one of those tricky ones. What are they supposed to do while they're there? And then what they do at home. And, you know, these are those graded things they can read about and kind of just see where they fit in. In terms of how long it took to get them to schools, if you look at some of the data on a pediatric population, it was around 8 days. And then back to sports was somewhere between 14 and 19 days. So that's kind of the average. But when I have a younger kid, like definitely the younger the child, I'll probably be going on even up to 6 weeks just to play it safe, because you never win by saying it's going to be too short. You say it's 2 weeks and they don't get better, then you're a bad doc. If you go 6 weeks, they get better in 2 weeks, you look amazing. So you don't really win by going by shortchanging it. But in general, know that most of the pediatric athletes by 10 should be at least back to school, because this is the return to school numbers. One interesting thing was about exercise. You know, we used to tell people not to exercise maybe 15 years ago. Now we actually encourage non-contact activity. So even if they want to go for a spin or a light jog. They shouldn't ride a real bike, of course, but like they should get their heart rate up. And as you can see, like against a stretching group versus they can exercise, they got 4 days faster to get back to their activities. Another kind of interesting paper here was that if you do cover sports, if the athlete was removed immediately, they got better faster. It was like all the patients lumped in. If they happen to play less than 15 minutes, they called that short play, and they got back, but a little longer. And then the long play, if they had a concussion, were left in the game, they did the worst. And the odds ratios were impressive too, that there does seem to be a higher risk if you don't pull the athlete out faster. So if you are covering youth sports and you think it's a concussion, yeah, don't let them keep going, because that could make a difference. All right, some final kind of recommendations that this group came up with. Mouth guard use is recommended in ice hockey and football, the big contact sports. They are starting to move away from getting a lot of contact at the young ages. So I'm Canadian, so ice hockey, when people were saying no checking, people were losing their minds. Now it's recommended. And then same thing with football. I wouldn't be surprised that they keep changing rules, because the numbers in American football are actually decreasing. A lot of parents are just thinking, I don't want my kid to play. And so they're probably going to need to make some changes to the rules so that they can keep participation going. But that neuromuscular training, there's a lot of exercise things, like we talked about that valgus collapse and just having good body awareness. A lot of these things can make that athlete also more nimble and avoid contact. So there's like the FIFA 11, which is from soccer, a lot of jumping drills, but they're doing these also just so that someone can avoid a concussion, like not collide with another player or fall unexpectedly and hit their head. So that's actually good evidence that works. Now, just around some kind of health disparities, unfortunately, African-American children are less likely to go to the emergency room compared to white children. So that means that diagnosis might be delayed, that they do have a concussion. People that have insurance are more likely to be able to get access to care and follow up. And then concussed kids are less likely to get academic support if they are going to get academic support if they speak English. So there's definitely not equal treatment when it comes to concussion care. Just as some opportunities, some studies in sports medicine have shown that, non-white athletes didn't know as much about concussions unless they had an athletic trainer at the school. So that's kind of a good plug for having an athletic trainer at most schools. Schools with athletic trainers helped make the diagnosis a lot of the time. So that's helpful. And having a concussion referral network where someone had a system and access to concussion care started to balance out who could actually access that. So fortunately, we have a really good group of athletic trainers at most of our schools here in the Bay Area, and same thing in the East Bay. So, we're continuing to work on it. And just to show you the resources that you have, these are the co-directors of the concussion program here. Matul Kapadia, you guys probably know him here at the hospital. Dr. Center, who's our chief of primary care sports medicine, and then Rhonda Watkins, who works mainly out of the East Bay. But then there's also the rest of the primary care physicians, including Dr. DeBorjas, who's here. She's pediatrics. And then we just hired Faustine Ramirez, who was a resident of yours. So I'm sure she's a popular favorite. So she's in clinic now. And I think she's going to maybe do some work in Marin. And then we have our great athletic trainer leads who help coordinate all these things. So if you call the clinic, they're going to get everything kind of worked out for you. All right. So I'll spend the last just few minutes just talking a little bit about the pre-participant physical exam. I called it risky business when I first did it. And this is kind of what the slides looked like at the time. We were always recommending all the kids to get a physical exam 6 weeks ahead. Because you know how it is, right? They come the night before practice or game is tomorrow. They want you to fill all this stuff out. You can't really do anything if you find anything. So you're just signing it off or not. So ideally, that education still needs to get worked through. But that's why we hold our physicals in May, not in the summer or anything, because once they leave school, they're gone. Now, these were in the manuscript. Why do we do a pre-partition physical exam? It was really to look for life-threatening or disabling conditions that they have and to detect any medical conditions or musculoskeletal things that would bother them from playing. But the number 3 thing was to address the legal and insurance requirements. And that still is a little bit, unfortunately, the nature of why that was there in the first place. I think we do a lot, because just getting them in and having that touch point where you can counsel them and even screen something is definitely helpful. And those are those secondary objectives that in sports medicine we believe in, just looking at the general health and just getting that access so you can talk to them about stuff. But, a lot of the parts of the PPE are still somewhat questionable. I'm sure you question it when you do it and you're checking them. They have no joint things, or you're listening to their heart. They have almost zero risk factors. Listening to the lungs, I don't think I've diagnosed anything listening to the lungs, but my wife's peds pulmonology, so I got to be careful there. But these legal things are something that we sign off on all these things, not to scare you, but again, that's why the school wants them all. And I think that's where you do get some people that do just sign off. And then there's all this controversy. Like the school board always asks us, like, okay, can a chiropractor fill this out? They did the musculoskeletal, but they signed off that they didn't do the cardiac. So it's really hard to say, like, yeah, that's okay, if I really believe that's what's supposed to be. But so the standard of care is always tricky. I do also think it creates a false sense of security. We think we cleared the kid, they're normal, they're never going to get injured. Like, no, it's the same risk. I'm not finding anything. That's all it is. So the EKG and involving the EKG, because that's something we do, and we'll kind of explain about that. But why did it even come out? What's historically there? Kind of in the mid 2000s, a lot of papers were coming out of Italy because in Veneto, they were doing cardiac screening on all the athletes, and they were reducing death by huge numbers because they're finding arrhythmogenic right ventricular dysplasia, which was like inherent to that one location. But they used to have a huge death rate with athletes in Italy. And then when they implemented this full screening, that was really successful for them. So that was kind of dominating the sports medicine conversations. The AHA came out and they said, no, we're not going to do that, because that would make huge implications if every athlete had to get an EKG all of a sudden. And so they've met a few times, the AHA, but over time, they've actually kind of changed as well, that there's some indications that maybe an EKG could be used in young athletes. And they say, the caveats in point 2 is that they have adequate resources and expert oversight. So I think they take you off the hook that you really need to do it on everybody. But I think for most serious athletes, I think NCAA programs usually get an EKG because, you saw LeBron James' son had an issue. Kids are getting screened and getting evaluated, and we still miss stuff. So the EKG is very effective for identifying most of the killers out there. And the rate nowadays is expected between 1 in 80,000 to 1 in 200,000, somewhere in that range. But compared to motor vehicle accidents, that's 5,000 to 1. So it's not that common. And so, the false negatives still are a concern as well, because even though they're cleared, there's still potential for some deaths with a normal EKG. So the pros and cons still exist for this. We've actually even identified some people. We've done maybe around 5,300 free screenings now 169 athletes followed up for some reason, not all cardiac. But we've had, Dr. Tennell in the group here. They've found a few Wolff Parkinson White and treated them successfully. So they're out there. Nowadays, they're getting easier. You probably noticed your iPhone can do your EKG now. I'm sure some of this EKG software might be able to save our cardiologists from reviewing thousands of EKGs. They've pretty much got a program that it can spit out what the scary things are. But the negatives are that just like the NBA, we haven't actually shown that the EKG really reduces a lot of fatalities. And then the incidence just isn't high enough to warrant it. And there's still false positives that do cost a lot for every workup. Just a comment about cardiac and COVID. That was a bit of a concern a few years ago. I think bottom line, just for sake of time, it's really only consider the EKG if they're symptomatic, because people that had cardiomyopathy, they all complained usually of some chest pain. And so you don't need to get an EKG even if they had COVID unless they have cardiopulmonary symptoms. Cool. All right. The last few are just fun slides. We're going to have our cardiac physicals on May 4th. So if any of you or the residents and students want to come out, it's definitely a fun time. The hospital has been really great at promoting this. Let me just hit play. The hospital market.
We're not just taping ankles and passing out water bottles. We have team physicians and athletic trainers in over 25 high schools in the Bay Area.
We screen young athletes for heart defects every year.
And we're on the sidelines if there's any serious injuries.
Most importantly, the PlaySafe program can actually save lives.
Good. These kids get to know us and trust us.
Yeah. Because we're all in it 100% to get them back to what they love.
Play safe.
Play safe.
Play safe. Play safe.
UCSF Benioff Children's Hospitals, redefining possible.
Cool. So yeah, well, our trainers.
We're not just taping ankles.
Just to show you kind of what the day looks like. This is an example. We probably do around 500 on average now. This will be our second year back after COVID. So people check in, they get their blood pressure and vitals done. We do an eye and height check. So we get a lot of the high school students to help out, and they even man some of these stations. There's Dr. Watkins in the medical screening. So that's probably the biggest thing. So for most of the pediatricians, they can help us out a lot here. Cardiac auscultation for the residents. We always want to check that left sternal border with them lying down and then standing up and looking for that increased loud murmur of HOCM. There's Dr. Hadamiya trying some of those VOMS tests. And then we do EKGs on site. So there's Dr. Scheinman. He's kind of a famous cardiologist here at UCSF. And he actually helped us get all this stuff started, because the school board kind of said, hey, why don't we do this free physicals? And I was like, okay, fine, I'll ask cardiology, but I don't know if they want to come out and do this. And I emailed them. He emailed back in 15 minutes, said yeah, then we're all in. And he's been able to bring people get EKGs, ultrasounds on site. So if they have something abnormal, they get screened with echo right on the spot. Some of the recommendations have been adding the mental health screening. So we do screen for that. And if they got anything positive, we have some specialists on site to talk to the athlete. And then there's the orthopedic department. There's Dr. DeBorja and Dr. Ma, our new chief of orthopedic surgery. So we do a lot of the education right on the spot, because you might know the biggest risk factor for injury is prior injury. And then we do a lot of education too, which is fun. So that we do teaching them how to do CPR. Pathology comes in, shows them livers and lungs and all the bad stuff that happen if you smoke. And then there's a nutrition station too, that when they're waiting in line, we force them to listen to stuff. So it's a pretty fun day. I think if you do a lot of PPEs, just like we talked about with concussion, you want to know your specialists that you might use. So if you're at the general, we got Dr. Canamere and Dr. Davies. They're our sports medicine kind of contacts. They're both orthopedic surgeons, but they're really well connected over there. And then obviously here you've got Selena, Rhonda, and Faustine. And then if there's anything we can do in primary care sports medicine, we're just down over north of the Gladstone. And there's always the e-consult system that we actually check that stuff. Oh, sorry. You want to take a picture? Awesome. And so like, I think takeaways for the MSK, work on the core and the hip for a lot of those knee problems, manage the load. You might be getting kids using wearables. And then those 3 questions that I have for return to play. If you use that, that hasn't failed me yet. And then for concussion care, just take a look at those new concussion guidelines. They're pretty useful, and you can make copies in your office because that's the new recommendations. And mental health is kind of getting into all our evaluations now. So just highlights the importance there. And on the cardiac physical side, maybe you'll be free to join us on May the 4th. So it's all the people we kind of bring up. So thanks so much for all your attention, and happy to answer some questions.
The Zoom yet. There's a robust audience there, so people might still come. If I may ask a question.
Yeah, sure.
So I'm originally from the Netherlands. Soccer is the big game there, and there's now been decades of evidence showing that hitting the ball with your head over time actually doesn't help your cognitive function. But it hasn't really changed the rules of the game. So you were mentioning changing the rules in ice hockey and football. Like, how likely do you think, and what kind of advocacy needs to happen to have rules that are so ingrained in a cultural game?
Right. So the question was around soccer and any rule changes and how do we make change there? Well, you know how fanatical people are about soccer. If people are crazy about the NFL here in the States, like soccer's even maybe more. The rates of concussion in soccer, especially from heading the ball, isn't actually that high, which is good. Usually it's going to be head-to-head contact with 2 players going for the ball. And so from that point of view, it goes by the risk. I think they don't see that. If you talk to more soccer players, they're not going to feel concussions the biggest concern in their sport. So I think if it does become, it's really advocacy and really who you're trying to protect. I think you see in the NFL, they're implementing some more rules because they want to protect the quarterback, let's say, or the high net worth athletes who are getting really hurt badly. And I think with sports, there's always that risk. So I think if the top players got a concussion, I don't think that would change hardly anything. But as you saw in the NFL, like I think some of the stories, the athlete stories, like you might have remembered 10 years ago, concussions was really a big problem. Like athletes were committing suicide from the mental health issues and just the chronic headaches. And I think those stories really changed public perception on what the NFL should do. And as you kind of see, you don't see those kind of stories. They implemented concussion, like third-party concussion specialists. So if someone goes down, it's not the team doctors that actually see them. This external specialist has to see them. Like I think, I don't watch as much soccer, but if it were to happen a lot or become statistically or detrimental to the game, I think they could use those kind of examples.
Just to quickly add there, I think at least in the youth soccer leagues, they don't allow heading anymore.
Oh, okay.
So at least in the Bay Area, but it is an issue by the time they get to high school soccer. So I think it's a cumulative.
Yeah, because the issue I think with soccer is not concussion; it's just a cumulative impact on
Following on the head all
of
the
like
time.
small.
Yeah. Well, education and how to head properly, just like how to check properly, that those were all the debates that people thought, hey, it's not the checking, they just don't know how to check. But I think the problem in sports is it's all over the place now. Like the programs are just so many, and some coaches are trained, some are not, some cost a lot of money, some don't. And I think it's hard to get everyone to follow these things, because most of the coaches who are the most direct people with them, they're across the board. There's no standardization to their training.
Have you seen much of a shift with the local high schools in terms of making sure that the kids are sort of ramping up activity? You know, one of the things that I'm always struck by at the beginning of the season, that, you know, is the influx of kids coming in with knee pain and that kind of thing. And
Yeah.
especially, you know, the classic, the valgus
Yeah.
girl playing soccer who hasn't really been given the proper tools to try to do the hip flexor strengthening, et cetera. I mean, do you have a sense that the trainers are being able to influence the coaches in that way? Or
Well, we always try to educate as much as we can, but like, yeah, it's really dependent on that coach. Some of them do value that kind of stuff, but some of them are just coming in, just like the students are coming in, they're just showing up on day one and they're going. And so I think it's based, a lot of it has to go back to the athlete, that we educate them that, okay, you're going to play that sport. You don't just show up. You better do these exercises early, because I think the coaches just don't have enough time. It's, even if they knew how, like, you get 1 hour in the gym and like, because there's 2 other teams fighting for the gym and you don't spend it. And then the kids are all over the place. If you've seen some of the school-based sports, and arguably San Francisco is not the most organized when you come to school-based sports. Some of this, if you go to the East Bay and the South Bay, some of these schools where the athletes are getting college scholarships, like, sports is way more serious. They got 1 or 2 athletic trainers. And then maybe those coaches are a little more educated. And so it's a tough message. I think if you have kids that do have stuff, just getting them to do something simple early, even if they started training 6 weeks where they're running a little bit and getting in shape. Because a lot of times they're just coming off of holidays, coming in and, like, you know, cross-country runnings in like 1 week. Go from 0 to running like 5K right away.
We're over time, but
Yes.
one more really important question from Zoom, and that is, are we able to volunteer for Play Safe on May 4th? And if so, who may we contact?
Yes, we're gonna, if it's okay with someone in the PEDS department, we'll make sure that information can get emailed out to everyone. I think we're just finalizing details, but we just wanted to save the date.
I'll forward it.
Thank you. Thank you. Thank you.
All right, very good.
All right. Thanks, everyone.